From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. Psychedelics used to be on the fringe of neuroscience research, but just as more people are using these drugs recreationally, they're also moving closer to the research mainstream. Psychedelics are being tested in treatment-resistant depression and other psychiatric disorders, and as we'll hear today, they're also now being investigated in neurologic conditions, including stroke. So why all the excitement? Today, I'll talk with Dr. Ghul Dölen, professor of psychology and neuroscience, as well as Bob and Renee Parsons Endowed Chair at UC Berkeley, and with Dr. Steve Zeiler, vascular neurologist and associate professor of neurology at Johns Hopkins. They are testing the safety and possible efficacy of psychedelics in stroke recovery. Welcome, Ghul, and welcome, Steve.
Thank you, Adeline. It's great to be here.
I'm excited to be here, Adeline. Thank you.
So let's start with the background and kind of the big picture behind this research into psychedelics. Ghul, you've spent much of your career studying childhood's critical periods. You know, these are the windows of time when a child's brain is especially impressionable and open to learning. And as we know, these critical periods naturally close in adulthood. But Ghul, you've had a paper in Nature with Nardu et al. Last year. I think you had other papers previously that demonstrated that adult mice who received psychedelics could reopen a new critical period for social reward. Tell us about this work and any other evidence that psychedelics can open new critical periods in adult animals.
Yeah, so actually, our first Nature paper, the first author was Roman Nardu, and it was published in 2019. And in that paper, we really focused on MDMA, which is a psychedelic drug that has a special property that makes it different from other psychedelics, namely that it's extremely pro-social. So when people take MDMA, the acute psychedelic effects are sort of what's typical of other psychedelics. But in addition, people report an interest in, doing 30-person cuddle puddles and just really, very interested in social behavior, but also dancing and other things that make MDMA somewhat unique. And we focused on MDMA because the critical period that we were studying was a critical period for social reward learning, which we think is important for all kinds of normal developmental patterns. For example, establishing your group membership, learning the rules of your social group, what's polite, what's impolite, how to defer to an elder, how to rank yourself within a hierarchy within your social group. So we focused on MDMA at first to test the hypothesis that it was this pro-social property of MDMA that was going to enable us to reopen this social critical period. And we were able to demonstrate that. We gave MDMA in adult animals when the critical period for social reward learning is closed. And when we gave it and then tested 48 hours later, we found that the critical period reopened. And suddenly the animals were able to learn from their social environment to the same degree as when they were juveniles. In the more recent paper, we tested something else. So we said, okay, well, MDMA belongs to this larger class of drugs, the psychedelics. Do the other psychedelics do it? And we were really surprised to find out that whether they had any pro-social properties or not, all of the psychedelic drugs that we tested also reopened this social critical period.
So yeah, as we've been talking about, there's this evidence now that psychedelics can reopen critical periods for social reward. But as we're going to move our discussion into the potential therapeutic use in neurology, I'm interested in what evidence there is that psychedelics can actually open critical periods in other neurologic domains like memory or attention or language or motor function. What evidence is there that psychedelics can reopen those types of critical periods?
Yeah, so the 2023 paper, besides just looking at other psychedelics like ketamine and psilocybin and LSD and ibogaine that don't have this acute prosocial property, the other piece of evidence to support that is that in the vast critical period literature, there's something like 7,000 papers that have been published on critical period mechanisms since they were first described in 1935. right? So vast literature on this. But in general, there are sort of roughly 3 mechanisms that people focus on as underlying how critical periods close and how we might be able to reopen them. And extracellular matrix remodeling and metaplasticity are 2 of the biggest theories about that. And so most of those theories were developed, though, by studying critical periods that affect cortical processes like vision or touch or motor learning. And so this mechanistic overlap between this emotional, social critical period reopening with psychedelics and the evidence suggesting that these same mechanisms are involved in closing and reopening critical periods that are sort of cortically governed really supports our view that these are the master keys for unlocking critical periods and that they will be able to do it elsewhere in the brain. And actually, besides the 2 mechanisms that were overlapping between the social reward learning critical period and other critical periods that had been described previously, one other clue suggested to us that psychedelics might be the master key for unlocking critical periods. And that is that the way that psychedelics have been used clinically in the research that's ongoing is that they have been used in specific contexts, right? So nobody is using MDMA and going to a rave and just dancing all night and expecting that your PTSD is going to be cured. Instead, every study to date of MDMA-assisted psychotherapy has demonstrated that the psychedelic is acting as a sort of assist for whatever therapeutic insight is coming from the therapy, right? So even in other psychedelic studies where they've looked at ibogaine or other psychedelic drugs, the durability and this sort of sea change that seems to happen with 1, 2, or 3 doses of a drug really seems to require that the psychedelic be given in the right therapeutic context. And this is really important because it's a change in the way that we understand how therapeutics are working in this space. The classical model of depression, anxiety, PTSD, addiction is we are trying to reverse a biochemical imbalance. That's been the working model in therapeutics for the last 50 years. And instead, what psychedelics are really suggesting and challenging that biochemical imbalance model is that it's actually a learning model. So you give the drug, you reintroduce the ability to learn. And if you give the right sort of learning protocol in tandem, then you have a durable learned effect that persists even once the drug is no longer active. And so our third demonstration, our third piece of evidence that psychedelics are the master keys comes from the fact that the ability to reopen the social reward learning critical period depends on the social context. And what that suggests to us is that if we just change the context from social to, say, motor, then we can open a motor critical period, and then it'll be useful in other diseases like physical therapy after stroke.
Great. And that's an excellent transition to my next question, which is really about the clinical use of these substances in humans. So, Steve, I wonder if you can give us a sense of how psychedelics are being tested in human populations currently, specifically in psychiatric conditions. What conditions are these drugs being tested in, and what exactly does it look like? How exactly are they being given?
So, Adeline, I think it's important to note that even though there is so much popularity surrounding psychedelics, clinically it is still experimental. It's still being tested, and we're still trying to figure out exactly the safety, the dose, and the way that these medicines can be given. Nevertheless, there are multiple studies, especially in the psychiatric domains, that have shown what appears to be benefit. And we are seeing this primarily in substance use disorders and mood disorders. In this group of patients, psychedelics are given and psychiatric therapy is provided during the trip at the same time that the psychedelics are provided. Based on Ghul's work, we have proposed an alternative use of psychedelics in patients with neurological trauma. For example, stroke, and that's what we're talking about here. That critical period remains open, and we can then act on it by providing a specific kind of therapy even in the days and weeks that follow the psychedelic trip.
Great. So let's move specifically to talking about stroke. Steve, we know that patients who have suffered strokes have only a short period of time in which they can regain some of the neurologic function that they have lost. And our tools during that period of time and also after that period of time can feel quite limited. When and how would psychedelics be employed to assist with stroke recovery?
Currently, and motor recovery has been most well studied, perhaps with language recovery a close second. We understand that motor recovery follows a fairly stereotypical timeline during which we see the majority of recovery in the first 1 to 3 months, with things plateauing thereafter. There's been a tremendous amount of studies and interventions trying to see how we can get patients better during that critical period of stroke recovery. What Ghul and I are proposing is that we can reopen the critical period of post-stroke recovery in those patients where that recovery has plateaued. In other words, we don't propose to interfere with the current standards of care. Alternatively, there are hundreds of thousands of patients annually whose recovery plateaus. They reach what is colloquially referred to as the chronic phase of stroke recovery. Their insurance stops paying for interventions, and we propose that we could, by giving psychedelics, reopen those endogenous repair mechanisms during which we could then provide the right context to continue that motor recovery.
Got it. So this intervention would be during what can often feel like a pretty hopeless period of stroke recovery where people don't foresee any potential future benefit and are just kind of supported to adapt to where they currently are. I'm curious why focus on that period and not on the earlier period of stroke recovery.
During that first 3 months of post-stroke recovery, you can see fairly efficacious recovery. In fact, studies done at a number of institutions, including at Johns Hopkins, show that about 70% of what you've lost, you get back during that motor recovery. I am of the mind that we can let the brain recover, and whatever we don't get back, let's give it another boost and do it again.
So how are you testing this?
2 ways. Number one, starting small, and I mean that literally, starting in animals. In other words, we have an animal model in the mouse of what the post-stroke critical period is. We have a timeline, and we can model motor recovery. And so we can test this in the animal, number one. Number two, we then move to the human, and we have a number of patients at least 1 year after their stroke who are left with a motor deficit that affects their daily lives. And the first step is to test the safety of psychedelics in stroke patients. The last thing we want to do is hurt people, and we have every reason to think, nevertheless, that psychedelics are safe in patients having experienced a stroke. But nevertheless, we start with a safety trial to make sure that it's safe, and then move on to test the efficacy in stroke patients thereafter.
So that's a bit about where we are right now with examining the potential efficacy of psychedelics in stroke recovery. What other neurologic conditions do you think psychedelics may someday help treat?
Yeah, anything that has immediate damage to the nervous system with a recovery period afterwards. Trauma is a big one. Multiple sclerosis is another one. Things that have a defined area of damage with a subsequent recovery period afterwards. Now, that doesn't mean that we couldn't also see benefits in anything that leads to degeneration in the nervous system. But my excitement lies especially in those areas.
As you've mentioned, there are many different types of psychedelics that have different mechanisms and that also produce different experiences in the person or the animal who's receiving them. And as we're talking about the potential range of clinical use, I'm thinking a bit about the experience of hallucinating. As a neurologist, I worry a little bit about some of my patients, especially people with cognitive problems, experiencing hallucinations and what potential risks that might pose. I know that there are some drugs in this class that don't necessarily produce the experience of hallucination, and I wonder if those are thought to be potentially effective too, or whether the hallucination itself is a key component of the potential therapeutic benefit.
Yeah. Let me break that down a couple of different ways. So one, not all psychedelics are hallucinogenic. So I broadly classify them into 4 groups: the dissociative psychedelics like PCP and ketamine, the hallucinogenic psychedelics like psilocybin, DMT, LSD, mescaline, ayahuasca. These are all sort of the serotonin 2A receptor binding hallucinogenic psychedelics. And then you've got MDMA, which is kind of in its own category with a couple of other less known drugs that are called entactogenic. Some people like, I prefer empathogenic. And then the 4th class is the onirogenic ones, like basically the main drug in this category is ibogaine. I think early on, there was this intuition that we could learn a lot about the psychedelics by breaking them up into these different categories, understanding which receptors they bind to, and that would give us some mechanistic insight. And what our studies have shown is that psychedelics of all of these 4 different categories, all are able to reopen this critical period, whether they have a psychedelic hallucinogenic property or a psychedelic dissociative property or onirogenic or empathogenic, right? So they all do it. What's different across them is the duration of the critical period that gets open. So if the trip is short, then the duration of the open state of the critical period is short. If the trip is very long, then the duration of the critical period opening is also very long. And so that is our best evidence, in my view, that the trip matters, right? That you can't just engineer out the trip and preserve this critical period opening property. So, for example, microdosing specifically, when we looked at that in the 2023 paper, we found no evidence that microdosing reopens this critical period. And in fact, in controlled trials, microdosing doesn't seem to have any therapeutic benefit in terms of depression or any of these other psychiatric conditions as well. Now, back to your original point about, well, are there some patients that we want to be careful about using these drugs in? And I would say, yes, there are. There is evidence, for example, that autism and schizophrenia might be diseases where critical periods fail to close in the proper way. And so in those patients, I think we want to be really careful about just giving psychedelics unless we've corrected the underlying imbalance or disorder, and we just want to go in and use the psychedelics in this learning way.
One other just question about safety. We've been focused on the research aspects of psychedelics, but, I think all of us, not just Ghul and I here in the Bay Area, but all of us are hearing more and more about recreational use of psychedelics, including, as was mentioned, the ingestion of small doses of psychedelics, the practice called microdosing, which has become a lot more common in recent years. And Steve, I wonder if you are hearing from patients with stroke or if your colleagues are hearing about patients with other neurologic conditions who are experimenting with these substances on their own terms. What would you counsel such patients with neurologic conditions who might be tempted to do so?
The use of anything off-label always carries with it the potential for side effect. We don't know what the safety profile is, and we don't know what the efficacy is. And so at this point, unless it's done under the auspices of a trial where we can track these things very carefully by the people who have created the study, as well as by safety officers who are overseeing this study, I would say it's a bad idea. Ghul said this at the very beginning of the interview. She said that you don't take a psychedelic, go to a rave, and expect to get over your PTSD. I've said that so many times to patients who have asked about psychedelic use for a therapeutic recovery. And I say exactly that not only do we not understand the safety fully, but even if it's completely safe, it has to be paired with the right therapy in order for it to have an effect.
I think that's good guidance, that there's more to learn and that caution and patience are probably warranted right now. A final question for our researchers in the audience. Psychedelics are still listed as Schedule I drugs under the U.S. Controlled Substances Act, and that can be daunting, I think, for researchers who might be interested in working with these drugs. So for researchers who might be listening, what barriers would they have to overcome, or what guidance would you give them if they're interested in pursuing such research?
I'm going to answer first because I had the wonderful opportunity to work with a colleague at Johns Hopkins. Her name is Ghul Dölen, who had a DEA license. In order to obtain psychedelics, you have to have a Schedule I DEA license, and that's to obtain either for animals or for human use. And that is a different license than what most physicians have to prescribe most medicines, like whether it be Keppra, Cellcept, or anything else. Ghul left me to be at Berkeley. I am now obtaining a Schedule I DEA license, which, as you correctly point out, can be a bit daunting, but it's nevertheless a thing that is easily done and a hurdle that is easily overcome. And it's no different than having to go through any of the other paperwork through which one has to go through to accomplish meaningful research.
Well, such a fascinating discussion, really helpful to learn more about this relatively new corner of neurology and neuroscience research, but one that we're, as we've discussed, hearing more and more about in just our everyday lives. So thank you, Ghul. Thank you, Steve, so much for joining us here on ANA Investigates.
Thank you, Adeline. It's been great.
Thank you.
That was Dr. Steve Zeiler, Associate Professor of Neurology at Johns Hopkins, and Dr. Ghul Dölen, Professor of Psychology and Neuroscience at UC Berkeley and Bob and Renee Parsons Endowed Chair. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Michelle Johansson. I'm Adeline Goss, podcast host and executive producer. Our program was produced today by Caitlin White and me, with help from Jen Hurley. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.